Good morning, everybody, and welcome to our abnormal pelvic ultrasound class. Today, we're going to have a 2 hours non-stop travel through the pelvic anatomy, starting with some very basic images on normal female pelvis. Remember that the world does not need you to do excellent things, but to do whatever you do in an excellent manner. So if you don't have the fancy machine, you don't need to. You just make sure you do your best. Let's go. This is a vaginal approach image of a uterus. The tip of the transducer is up on the screen. Let's use our laser here. This is the tip of the transducer and is nearby the anterior wall of the uterus. This is the cervical channel, cervix, and this is the endometrium. This is the uterus contour, well-defined, and the posterior wall of the uterus. This is the fundus, this is the cervix. Depending on how you take the transducer, you can have different images. This is a render reconstruction or 3D reconstruction of the same uterus. And this is a view of a uterus using the transducer in the opposite way. Sometimes we take the transducer in one way or in other way. Just make sure you know what you're looking at and what's the orientation. The tip of the transducer on the vaginal wall close to the anterior wall of the uterus on the axis of the endometrium, which is this line, and away the posterior wall of the uterus. This is the fundus, and now the cervix is in the opposite side of the screen. And I render this reconstruction. Whenever we see a patient who needs or asks for a pelvic ultrasound examination, it means that that person had a problem or think she has a problem. Cheers. Early coffee mug. Okay, this lady complaint is pelvic pain. Let's see what happened if we search on her pelvis through the transpelvic approach. Here we're using a convex probe, suprapubic, and let's see. That was an ovary. Again, that was a complex ovary. Again. Okay. Else, the ovary, the uterus, and something in the uterus. Something really small. Let's see how we can improve that. Improve the diagnosis. This is a frozen image of what I called a while ago a complex ovary. This is not the regular image of an ovary. There are some echoes of medium intensity, some free fluid surrounding the ovary, probably inflammatory. And in the uterine view, we have a small collection here on the anterior wall of the isthmus. This is on the area of a previous cessation. If we use the transvaginal approach, we can see the ovary like that. Which most probably happens to be hemorrhagic corporal luteal or luteoma. This happens from time to time whenever there's an ovulation. Sometimes the rupture of the follicle takes a blood vessel which bleeds inside the ovary, and it takes some time that blood to reabsorb. In fact, sometimes we see small, bright echogenic things, which are usually hemosiderin deposits inside the ovary, inside the cyst, inside the hemorrhage. See, there's a small amount of free fluid here. And now we move to the uterus and see the small collection that I was talking about. We call that isthmocele. And isthmocele is a pouch-like area inside the uterus in the area of a previous C-section repairment connected with the cervix and with the endometrial cavity. Sometimes this causes pain. Sometimes this causes abnormal hemorrhage. Sometimes this even can be a cause of fertility problems. And the remedy is usually surgical with minimal invasion repairments or laparoscopy. Let's see again the collection connected with the endometrium and the cervix. The complex ovary with free fluid surrounding it. The uterus on the transpelvic approach with the collection here. There's other side of collection, which is frankly in the endometrial cavity, not on the isthmus, not on the previous section scar area, and we call that hematometra, and we will see some images pointing to that diagnosis. This is a collection inside the endometrial cavity. The endometrial lining is all the way to there. This is a collection on the endometrial cavity from a transpelvic approach. This is a collection on the endometrial cavity from the transvaginal approach. And those are the ovaries, right and left ovary, normal. The rendered reconstruction of that collection, a nice picture of that collection. Now, different patient. The coexistence, I'm choosing patients with several problems because that way we kill two rocks with a bird. This is a patient with fibroids and an endometrial polyp. Let's take a look at it. This was really fast, but let's see. This is the endometrium. Those are the fibroids. And let's search for the polyp on the endometrial lining images. This is not regular. See? This is not a triangle-shaped endometrial filling. Those are the fibroids. The fibroids again, and in this vaginal view, you can actually see the endometrial mass. See this white, bright dude here? That's not normal. Again, endometrium, fibroids. Now I bet you saw the white thing. Let's repeat that. Could we spot it? Yes, here it is. If you need to scan slow, scan slow. That's the polyp. And those are the ovaries. Those are follicles. Those are follicles. Let's move to adenomyosis. Adenomyosis is the presence of endometrial tissue inside the uterus. And it looks like this. This looks like snowflakes inside the uterus. That hurts. Fibroids usually don't hurt. Fibroids don't hurt. If it does hurt, she must have something else. And it could be adenomyosis. Spots like snowflakes. A very complex uterus. It's like having small spots of endometrium inside the uterine wall. The two ovaries of the same patient. One of the great mimickers in the pelvic examination is endometriosis. Endometriosis can mimic anything or can be image silent, not to show much unless we perform a laparoscopy. That's not the typical diagnosis that we can do just by ultrasound imaging. In fact, for staging that, we need laparoscopy. That's a complex anexa with the topography of the right ovary very complex. With an image alike the hemorrhagic corpus luteum we saw on the first slides. Those are usually pelvis that we cannot easily move. If we push with the transducer, we cannot separate adnexa from uterus. Sometimes that's what we call a frozen pelvis, which you cannot really displace or move, especially without causing pain. That's the left annexa, and the right ovary or the right annexa with complex mass. So whenever we see complex things on the pelvis, we should consider the diagnosis of endometriosis. The other mimicker, especially if you're not skilled enough, lucky enough, or you don't have a good machine, can be ectopic pregnancy. Let's take a look at how ovaries under IVF protocol look like. This is a baseline examination of an ovary with a lot of immature follicles. See the small round-shaped areas which are echo-free, black, in both ovaries. And during the ovarian stimulation, some of the follicles grow up. See this one? This is 6 millimeters. This is 1 centimeter, 1.2 centimeters. And the endometrial lining changes. By the way, we have an IUD inside. This is another patient under reproductive assistance, and we see with her that there's a submucous fibroid. See the round-shaped thing here, which pushes the endometrial lining up or front. And this is the transversal view of that mass. And both ovaries. Which under stimulation have some growing up follicles. And after the rupture of one or more than one of those follicles, we have the luteum corpus with some hemorrhage inside and free fluid. Another topic. What if we suspect a pelvis mass? Well, we need to know location of the pelvic mass, if that's a mass limited to the pelvis or outside the pelvis, inside the abdomen, and the exact relationships or the affected organs, uterus, adnexa, or both. The nature of the mass, which is if that thing is cystic, which usually is an adnexal, solid, which usually is uterine, or complex, heterogeneous echoes inside the mass. What is what we call cystic? A cyst is a well-defined, encapsulated mass. We can see the boundaries of that mass, not necessarily fluid filled, dark gray or black, because dermoid cyst or benign teratoma is a cyst, but it's not fluid. Complex usually is an excel of ovarian nature, like the luteinic cyst or cystic tumor, cystic complex tumor. The more complex a tumor is, the higher odds of a malignancy. Or it can be extraovaric, like endometriosis, cystic complex extraovaric mass, which can be endometrioma. We call it chocolate cyst. Now we're going to see dermoid cyst, also known as cystic benign teratoma. This is the most common adnexal mass on reproductive age. Real tumor on reproductive age, younger female have teratoma. And this is one of those. This is a small, almost rounded thing, which is highly contrasted with the rest of the ovary. What else it could be if not a teratoma? Former luteum body cyst with a lot of hemosiderin inside? I don't think so. This is not how big or small it is, but how does it look? And it looks like a dermoid cyst, and it was a dermoid cyst or teratoma. So this is the uterus, the left ovary, the opposite side ovary, and inside the right ovary, we have small, well-defined intraovaric mass, most probably dermoid cyst. Zooming in, of course, if we don't have a good context, it's not that easy to see. You know that patients are sometimes overweighted and full of intestinal gas, and we don't have this vaginal transducer, and we have to take a look at pelvises with whatever we have. This is a dermoid cyst as seen with an old machine with no harmonic imaging. This is a 5 megahertz convex transpelvic image of a complex ovarian cyst, which does not show clearly the posterior wall, the wall which is far from the transducer, but we can see some shadowing and spotting and complex things and a capsule. So take your time, be patient, and do your best, and you will have something to say to help that person to solve that problem. Say patient, which, by the way, was pregnant. We can see a lot, like 9 weeks, baby inside with the heartbeat. That guy. So if you work for giving information to others, describe what you did, and if you encounter this easily or not that easy, if we can move it or not, fix the mobile, focus on the user profile to report this. It's not the same to talk with the general practitioner or with a regular gynecologist or with a gyneco-oncologist. Be the more clear that you can. Write in better English than mine. So I describe that like a very heterogeneous, complex, and mobile encapsulated mass on the right adnexa. Most probably a dermoid cyst or benign cystic teratoma. If it's for you to refer to your own team to resolve, no fear. Nobody's going to criticize you. And if so, no fear. You're doing your best. Don't be mentally cheap health provider for the patient. Do your best. Here, it's not an easy to see mass, but here we can see it shadowing, posterior acoustic shadowing from something that we don't clearly see. If you pass through here in a rush, you can infer that this is intestine, and it's not. That's an ovarian anterouterine mass. This is the uterus. And this is on the right ovary because the left ovary is normal. So there's not such thing as a perfect observer, not mechanical nor human. The human eye does not differentiate 256 gray shades. We can find 256 gray shades in the ultrasound machines. On the Virgen de Guadalupe picture original, we can have 256 gray shades. And it's something that appeared on Mexico in 1531. That's a miracle. But this is not a miracle. This is reality. So be organized on your scan, be focused. And remember, you're not perfect, but you're doing your best with your resources. Sometimes we are second opinion of something. There's people who a colleague can think is has a fibroid because something moves with the uterus and find a teratoma or another nature of mass, which is here, anterior to the uterus. And when you move it with the bimanual examination, you can move it with apparently with the uterus, but not. This is apart from the uterus and is a complex adnexal mass, plus a inserted IUD. Variations of the same tune, more teratoma, so that bright area there. Let me show you. Here, it starts here. We have a shadowing. When we pass through here, that's a complex echoes inside our ovary with 2 areas of acoustic shadowing. That means there's some bone or cartilaginous tissue inside the mass. That's a teratoma. Adnexal solid cystic-like mass. Same adnexas. Solid in echoes, but cystic in nature mass, complex cyst teratoma. From the vaginal approach, same thing with more details and acoustic shadowing. You don't always you don't have to find an acoustic shadowing in order to be very accurate to guess a teratoma. Those are the ovarian blood vessels and the teratoma. Again, the ovarian blood vessels and the mass, the teratoma. Again, in a closer view, you see those changes of color. That usually means that the pedicle is twisted, and this is hurting. And this can be an abdominal or pelvic emergency situation. You cannot let the patient go with that kind of pain. Again, different, complex mass. This is hairy, and in fact, sometimes those are hairs. This looks like the nuchal image of a fetus when you see the baby's hair in the amniotic fluid. But this is not a baby. This is the right ovary, this is the left ovary, and this is the uterus. This is a somehow transverse view from the pelvis of a complex ovarian mass. And this is the longitudinal view or right parasagittal view of that same mass, which looks like a teratoma. Easier to see here because of the shadowing, not that easy to see here with a small amount of free fluid surrounding there. Whenever there's pain, sometimes that mass or that cyst is twisted because if the ovary weighs more than usual, the pedicle can twist, and that hurts. If the patient has an appendix and that's a right ovary pain, sometimes we have to document a normal appendix, like this one we see here, surrounded by some free fluid. See the free fluid behind the uterus? Thick endometrial lining, right ovary. And the pain was right because the left ovary was twisted to the right side. And it hurts. And the arterial velocity is modified. Okay, let's move to pediatric pelvis masses. That's not nice. Whenever you see a female child with a pelvic mass, you can be looking at a malignancy. It could be a dermoid cyst, or it could be a dysgerminoma or another kind of malignancy on a young girl. This is the small, normal to the age uterus, 4.4 centimeters, right ovary, left side, complex mass. Sometimes we can find masses on the adnexa even before birth. Before birth, I saw this. Day before Christmas, 2010, 41 weeks among to be taken out. Next year, July, pelvic complex mass, 7 months old with no previous investigation, regardless the documented finding. Nobody cared about that. She was waiting to see what happens next. And then somebody said, oh, let's do an ultrasound, remember? Well, this child had a complex mass. Sometimes those masses appear in not that young little girls. This was a preteen with a pelvic big mass. Well, really big. That was an abdominal pelvic mass. This is an extended view with some of the tricks you can do with a good machine or expensive machine. And find complex masses in young girls, which usually are malignancies. And I had shown this several times. This was a 18 years old girl which underwent surgery because of an ovarian cyst in the USA. That happens to be ovarian cancer, germ cells type. And she followed the natural course of that disease, which is she passed away. We found low speed flow on septations of the complex cyst. And we did some follow-up on her because she was under any kind of treatment you can imagine. We even found liver tumors, metastatic liver on her, and masses in places other than the original place. This is a subsplenic mass. That topography usually is from a lymphoid component. Another case of cancer in a more mature woman, which usually shows like a complex septated with echoes inside mass. Still cyst, which is not all black inside cyst, but complex with septations. Same patient, same mass. This is a different patient with a complex cystic complex mass, which share vessels with the left ovary. fixed to the uterus without sharing blood vessels with the uterus. See, there's no connection here. There's connection here. There's no connection here. There's connection here. There's no connection with the uterus. Pelvic complex mass with some free fluid. This is the left ovarian artery going to the mass. And another cystic complex ovarian mass. We are not pathology, but we can mention what it looks like. That's useful for the surgeon or for the physician in charge. Another ovarian cystic complex mass with clear vascularization of the septations. This whole thing is the mass. And anybody can have two things, two diagnoses, two problems, two findings. Here we find a uterus with fibroids plus an ovary mass. Uterus with fibroids and an ovary mass. An ovary mass. And abnormal images after surgery, hysterectomy, which are cystic-like. But this looks like a twisted tube. See that? More like a twisted tube more than a ovarian cyst. This is another mass, left side, complex, behind the ovary. Here, see? Those are the ovaries. There's a mass behind the ovary, besides the ovary. What's this? It could be endometriosis. Remember the great mimicker? Chronic pelvic inflammatory disease. Once you do a laparoscopy, you will know. Not an ectopic pregnancy because she had pain and a negative pregnancy test. Then this lady, somebody performed an ultrasound examination on her and said, "You have a cyst on an ovary." Well, in order to say you have a cyst in an ovary, you must see the ovary and see the cyst and relate it to the ovary. This is a scan on the upper right side of the pelvis, almost upper abdomen. And I didn't see ovary or uterus. Not related with that. So let's search for the ovary. Here we can look at the pelvic blood vessels, the uterus, and this is the ovary. What do you think about that? This is the ovary. Again, the cyst was here. Uterus moving to the right side, and by the side of the uterus, this thing. Uterus. By the side of the uterus. Transverse view. Left ovary. Right ovary. Vaginal. Ovary. No cyst inside. The opposite side ovary with follicles. Those are not veins or arteries. These are veins and arteries. These are follicles. See, we improve the image. You can clearly see the ovary. No cyst. In fact, we don't see the cyst to the vagina because it's too far from the vagina. It's high. So this is a normal right ovary with a simple cyst outside the ovary, not related with the ovary. Sometimes those are paraophorous cysts. Those small cysts which hang from the tube and just are good to confuse ultrasound people. Normal right ovary, no cyst, nothing related to that. The cyst, intestine, cyst, intestine, the cyst, intestine. What about non-gynecological cysts or cyst-like things? Here we have the urinary bladder and something behind the bladder. So that was flow. Again, flow. If we press on the bladder or press on the pelvis, there's flow between the cyst and the bladder. So that's not gynecological, that's urological. That's a bladder diverticulum. See that? Beware the flow. See that? Again. Ultrasound is clinic information because number one is bedside examination and number two is a prolongation of your sight. You're looking at things. You're not inventing things. More of a complex pelvis. Bladder, complex adnexa, or behind the uterus. This is the uterus. This is a big, complex thing which evolves or involves the ovary and who knows what else by the side of the uterus and behind the uterus. That's endometriosis. See that? It goes all the way from one side to the other. Again. Why this is not an ovarian tumor? The number one complaint is pain, not weight loss, bad shape, no, just pain. Pain during menstruation, dysmenorrhea, which have been increasing through time since she was young, and a complex pelvis. That's not cancer, that's chocolate inside. That's precisely like menstruating inside. Complex pelvis, endometriosis. See the spots, the bright spots that hemosiderin I told you about? Transverse view, really complex thing which surrounds the pelvic organs. That was the uterus here. This one. And who knows which part of the image is ovary. Vaginal approach. Complex mass. We don't actually see blood vessels inside, but on the peripheral layers. No blood vessels inside. Blood vessels here, probably in which is the ovarian pedicle, but not inside the mass itself. Again, blood vessels in the ovarian pedicle, but not on the mass itself. Those are the pelvic arteries, the iliac artery and vein. So let's move to a different problem. This is a lady after the C-section with a collection inside the uterus. This is the area of the uterine repairment, the C-section scar, cervix, which is closed, and that's why this is collected. I know some obstetricians that open the cervix before they close the uterus, but this can contaminate the surgical area. So this is not a usual thing to do to most people. But sometimes, if especially when people perform C-section without labor, the cervix is closed and will stay closed. And then some bleeding can stay inside. After a miscarriage is same problem. You can have collection inside after a miscarriage. After a DLC, this is a retroflexed uterus. Physically can be harder to get through to the blood if the contractions of the uterus are not that easy to spread all the way to the less resistance area, which is the cervix, like in a really retroflexed uterus. And now we're going to take a look to several thick endometrium images. Endometrium can be thick because hormonal changes, endometrial abnormalities, and endometrial malignancy, or early pregnancy. This is an endometrium which is 11.7 millimeters from anterior to posterior wall, measuring both layers. What's considered to be thick? Well, that depends on the stage of the cycle the patient is, and between 5 and 10 millimeters, pretty decent. This is mildly thickened endometrium. The thick endometrium, 1.3 centimeters or 13 millimeters. In the normal size uterus, usually there's not a problem, not a malignancy. In a normal size uterus, that's not usually a problem. We see a round thing here. See that? That's a normal functional follicle in the ovary. Sometimes uterus are mildly enlarged and endometrium is thick, and the patient has been bleeding abnormally, so that needs further investigation, an endometrial biopsy, DNC, for therapeutic and diagnostic purposes. Some uterus are more enlarged. This is a 11.5 centimeters high uterus with an endometrium which is 15 millimeters. The uterine volume is high. And there's a really thick endometrium with a normal size uterus. Most of the times is due to hormonal issues. Endometrial malignancies usually are seen in bigger uterus. This is a mildly enlarged uterus with a really thick endometrium. Endometrium is not this, it's all the way through here. This is the posterior wall of the uterus. This is the anterior wall of the uterus. Follow the myometria. This is the endometrium. It's very complex and really thick. Some free fluid. Really thick endometrium. An enlarged uterus, almost 13 centimeters. Really thick endometrium, not very enlarged uterus, but abnormal bleeding. We can find that in all sort of instances, like after people takes the so-called emergency pill, that's what it is supposed to be happening, having early abortions or miscarriages, or calling whatever you call it. An endometrial mass posterior to a DNC with an abnormal bleeding. She keeps bleeding. Why? Because she had this. You don't take out this with a blind procedure such as a DNC. In order to take this out, the better way is hysteroscopy. You take a camera and go inside and go for it. And sometimes you don't find a fake endometrium, but a collection. And that collection helps you to see what's happening inside. This is an endometrial polyp, an abnormal thing inside the uterine endometrial lining without thickening on the endometrium. This is an endometrial polyp, not that evident until you use the vaginal approach. And this is not a polyp, but a fibroid. It's a fibroid because it's modifying the endometrial lining. It's not inside the endometrial cavity and growing from the endometrium, but from the myometrium. See this? Okay, let me show you the render, the reconstruction of that. This is a nice pic of a submucous fibroid. Don't try that back home, people. Let these to professionals. No, bad joke. I know your professions. Submucous fibroid. Not easy to see. Same, hysteroscopy. The final diagnosis and treatment will probably be during hysteroscopy. This is the mass, zooming in a 3D rendering. This is the mass. Another submucous mass, hematometra, and uterine synechia, which is scarring tissue between the uterine walls. You can almost see it here, but here is clearly seen on the transverse view from the anterior to the posterior uterine wall and some submucous mass. That's the cervix, mildly enlarged uterus because of the collection, I think. The volume rendering of that. This is mimicking laparoscopical view, but this actually is a render reconstruction of surface of the uterus from the belly. And this is the complex mass. If we have a limited resources machine, we can also diagnose that. Endometrial line mass, which comes from the myometria and gets enlarged inside the endometrial cavity, is a submucous mass, most probably a fibroid. And this is the transpelvic approach and the vaginal approach. A very complex uterus with that submucous mass. See this? The material is like this, complex uterus, probably adenomyosis with the submucous mass. See this? This is spreading the material lining. This is another case of a submucous mass. See the endometrial lining mass inside. It's like here. This is another submucous mass. Small. They don't have to be huge in order to provoke bleeding, pain, spotting, pain, postcoital spotting or bleeding, pain. This is a submucous mass. All those need to be referred to hysteroscopy if possible. Abnormal adnexa loss, submucous masses. This is a complex mass. I thought it was ovary, but it looks, at a second thought, it looks more like a tube, a twisted and inflamed tube. See that? That's the usual hydrosalpinx image. What is this? A polyp or a fibroid? We don't have to name accurately everything. We just have to know who to call for resolving this. So the guy with the hysteroscopia, a submucous mass, polyp or small fibroid, who knows until the hysteroscopy? Same patient. Okay, see that? Somebody prescribed estrogens. A year after that, uterine length, 11 centimeters. Uterine length, a little bit more than 11. Well, consider it same, but still, the submucous mass. Usually those things don't shrink with estrogens, and it's not a dysfunctional bleeding. You don't treat that kind of bleeding by prescribing hormones. Now, fibroids, we classify that as small, medium size, or big. Those are small, less than 2 centimeters diameter fibroids. Big, bigger than 4 centimeters wide. That's 8 something, 7.5. Big subserose, which means behind the outer layer of the uterus. Big fibroids, subserose, you see the uterine shape changes. Fibroid, endometrium thick. Submucous fibroid, endometrial lining. Septate uterus and fibroids. Now, uterine collection, hematometer, and low insertion or low inserted IOD. This is in contact with the internal cervical os and far from the fundus, more than 2 centimeters from the fundus, this is low inserted. This is a patient long time ago. With a bicornuate uterus, a septated uterus, this is transverse. Pain, fever, and bleeding. This is the endometrial width, 1.9 centimeters. On one of the sides, not on both sides. If you do a blind procedure like DNC, you can actually clean one side and keep leftovers inside the other side. This is a patient with bleeding on the late puerperium, which is not supposed to happen, which actually had some placenta retained. See the complex thing inside the endometrium. And this case of that abnormal bleeding after taking the so-called emergency pill, well, she had an incomplete abortion or incomplete miscarriage. Call it as you wish. Bleeding after miscarriage and misoprostol, endometrial lining, something inside. Change in subject. This is an image after obstetric hysteroscopy, which usually is subtotal because it's not easy to take the cervix out with everything inflamed and modified, and you can actually put in more danger the patient or cause injuries to the ureters or to the bladder. And this is one of the last cases we will see. 3 months after delivering a baby, the patient still had bleeding, some discomfort, nausea. Is a somehow bicornuate or septated uterus. On the long view of the right horn of the uterus, on the right side, we see endometrial lining. On the right side, we see this. This is complex, and we have an abnormal area here. Which on the transverse view looks like this, with a small collection inside. If we use the color flow, those are the ovaries, no luteum cyst, but I wonder why the uterine arteries 3 months after delivering a baby still have low resistance. This is usually the pattern of blood flow during pregnancy, if normal, not if high risk of preeclampsia. This doesn't even have a notch. This is very normal for a pregnant uterus, but not for after 3 months of delivering a baby. What's happening? Well, on the left side, see this? There's a low resistance vascular bed surrounding the mass we saw, which is there and which was a trophoblastic postpartum disease. A trophoblastic tumor of the placentary site insertion. We're not supposed to be looking at something like that inside any uterus. That can even be a choriocarcinoma. This is his main blood vessel. See how low the resistance is? Of course, with a collection, because this bleeds inside the uterus. So, what can we bring home? There are several causes of asking for a pelvic ultrasound examination. Usually, we cover that with abnormal bleeding or abnormal menstruation, pelvic pain, or palpable mass. The most common cause of getting inside my office with pelvic pains is not ovary, it's irritable bowel, colitis, the worrying because the husband, the kids, the dog, the cockroach, neighbor, whatever, plus what we eat. We cannot control things on the context, but we could control what we put inside our system. And if that doesn't help to our intestinal health, we can actually have a bad case of colitis. But don't be that smart. You must perform the ultrasound. And once you perform the ultrasound, you see if you press and it's the intestine, what hurts of if you find something else. So number one cause of pain is irritable bowel. Causes of bleeding, abnormal bleeding, IUD, endometrial causes, fibroid, not taking properly the contraceptive pills or taking the emergency pill. Of course, that can cause bleeding. The main cause of palpable mass that I feel like something is number one, you don't have a mass. Thank God, most people doesn't have a tumor, but number one cause of you feel something other than a pregnancy is a fibroid. And a uterus enlarged by a fibroid, you can feel it by your hand. But in order to say that's your colon, not your ovaries, you must clearly see both ovaries and unrelate that to the sensitive area. And I bet you will do. Just don't press too much. They will kick you. Remember, fibroids don't hurt. Fibroids don't hurt. There's a professor in Canada, Dr. Edward Lyons, which could perform a lecture and repeat like 55 times in an hour. Fibroids don't hurt. If it hurts, it's not the fibroid. Fibroids don't hurt. Adenomyosis hurts. Not all bleeding comes from fibroids. Investigate endometrium. It's not that hard. You should clearly see the endometrium. If you don't have vaginal probes, feel bladder, full feel bladder, and then you will see the endometrium. Don't rush. Don't make diagnostic conclusions before being sure. Don't make conclusions because before looking at the patient. Sometimes I'm like that good. People get inside with a piece of bread and a Coca-Cola, and I say, you have colitis, and then boom, an ovarian tumor. shut up, Pedro. Don't open your mouth until you have all the information you can have. Nobody has the 100% of the information of any context. But remember, we have to build in ourselves the capacity of saying, I don't know. Sometimes you don't know. But after good ultrasounding, we usually know better because ultrasound is not biased. As we actually see, it's clinic evidence. It's a prolongation of your sight. You're looking at things. So, as in every lecture I said, let's do our best with whatever machine we have. Ladies and gentlemen, this is Pedro Velderrain from Mexico. Been a pleasure. That's my email address and my website. Thank you, everybody.